Welcome. Today, we're diving deep into a fascinating yet complex area of neurology, pre-synaptic neuromuscular transmission defects. These disorders affect how nerve signals are transmitted to muscles, specifically at the point where the nerve meets the muscle, known as the neuromuscular junction. We'll explore what causes these defects, how they disrupt normal function, and what can be done to manage them. So, what exactly causes these pre-synaptic neuromuscular transmission defects? The primary culprit is often an autoimmune attack. In these cases, the body's immune system mistakenly identifies components of the pre-synaptic terminal, that's the end of the nerve cell that releases neurotransmitters, as foreign and attacks them. Specific targets can include voltage-gated calcium channels, crucial for neurotransmitter release, or other proteins involved in vesicle fusion. Less commonly, genetic mutations can directly affect the structure or function of these proteins, leading to inherited forms of the disorder. Sometimes, exposure to certain toxins or drugs can also disrupt the delicate balance at the neuromuscular junction. Let's break down the pathophysiology. Normally, when a nerve impulse reaches the pre-synaptic terminal, voltage-gated calcium channels open, allowing calcium ions to flood into the nerve ending. This influx of calcium triggers the fusion of vesicles containing acetylcholine, the primary neurotransmitter at the neuromuscular junction with the presynaptic membrane. Acetylcholine is then released into the synaptic cleft, the space between the nerve and muscle. In presynaptic defects, this process is impaired. If calcium channels are blocked or damaged, or if the proteins needed for vesicle fusion are dysfunctional, less acetylcholine is released. This means the muscle fiber doesn't receive a strong enough signal to contract properly, leading to muscle weakness. The exact epidemiology of pre-synaptic neuromuscular transmission defects is difficult to pinpoint because some forms are quite rare and can be misdiagnosed. Lambert-Eaton myasthenic syndrome, or LEMS, is the most well-known example and is often associated with small-cell lung cancer. The incidence of LEMS is estimated to be around 3.8 cases per million people. Other pre-synaptic disorders are even less common. These conditions can affect people of all ages, though LEMS tends to be more frequently diagnosed in older adults, particularly those with underlying malignancies. The hallmark symptom of pre-synaptic neuromuscular transmission defects is muscle weakness. This weakness often improves with repeated effort or exercise, a phenomenon known as facilitation. This is because repeated nerve stimulation can sometimes increase the amount of acetylcholine released, temporarily overcoming the underlying defect. Other common symptoms include fatigue, particularly in the legs and arms, and dry mouth due to reduced activity of the parasympathetic nervous system. In LEMS, individuals may also experience autonomic dysfunction, such as constipation, blurred vision, and difficulty with urination. Reflexes may be reduced or absent. Diagnosing presynaptic neuromuscular transmission defects typically involves a combination of clinical evaluation and specialized testing. The key diagnostic test is repetitive nerve stimulation, or RS. This involves stimulating a nerve repeatedly and measuring the electrical response in the muscle. In presynaptic defects, you'll often see a characteristic incremental response, meaning the muscle response gets stronger with each successive stimulation. Single-fiber electromyography, or SESFEMG, is another helpful test that can detect subtle abnormalities in neuromuscular transmission. Blood tests to detect antibodies against voltage-gated calcium channels are also crucial, particularly in cases of suspected Lambert-Eaton myasthenic syndrome. Finally, imaging studies like chest CT scans may be performed to rule out underlying malignancies, especially small-cell lung cancer. While there aren't strictly defined types, in the same way as some other diseases, pre-synaptic neuromuscular transmission defects are generally categorized based on the underlying cause. Lambert-Eaton myasthenic syndrome, or LEMS, is the most well-known and is often categorized as either paraneoplastic associated with cancer or non-paraneoplastic autoimmune but not linked to cancer. There are also rarer congenital myasthenic syndromes that involve genetic mutations affecting pre-synaptic proteins. Additionally, certain toxins or drugs can induce pre-synaptic defects, which would be classified based on the specific causative agent. The treatment and management of pre-synaptic neuromuscular transmission defects focus on improving neuromuscular transmission and addressing any underlying causes. In Lambert-Eaton myasthenic syndrome, treatment with medications that enhance acetylcholine release, such as 3,4-diaminopyridine, is often effective. This medication blocks potassium channels, prolonging the action potential and increasing calcium influx into the nerve terminal. Immunosuppressive therapies, such as corticosteroids, azathioprine, or intravenous immunoglobulin, may be used to suppress the autoimmune response. In cases of paraneoplastic LEMS, treating the underlying cancer is essential and can often lead to improvement in neuromuscular function. Symptomatic management. such as physical therapy and assistive devices, can also help improve quality of life. Unfortunately, there are no specific preventative measures for most pre-synaptic neuromuscular transmission defects, particularly those caused by autoimmune mechanisms or genetic mutations. However, avoiding exposure to certain toxins or drugs that are known to impair neuromuscular transmission can be helpful. Prompt diagnosis and treatment of underlying malignancies, in cases of paraneoplastic LMS, is crucial in preventing further progression of the disease. Overall, a healthy lifestyle and avoiding known risk factors for autoimmune diseases may contribute to reducing the overall risk, although the evidence is not definitive. The prognosis for pre-synaptic neuromuscular transmission defects varies depending on the underlying cause and the effectiveness of treatment. In Lambert-Eaton myasthenic syndrome, the prognosis is closely tied to the presence and stage of any associated cancer. With successful cancer treatment and appropriate immunosuppression, individuals with paraneoplastic LMS can often achieve significant improvement in their neuromuscular function. Non-paraneoplastic LMS generally has a more favorable prognosis with immunosuppressive therapy. Recent research is focusing on developing more targeted therapies that specifically block the autoimmune attack on the pre-synaptic terminal, potentially leading to more effective and less toxic treatment options. Studies are also investigating the role of specific genetic mutations in congenital myasthenic syndromes, which may pave the way for gene therapies in the future.